I personally am grateful for the opportunity to be here. I wanted to be here. I asked that if at any time we had a public session, that I'd like to be part of that process. And again, thanks to the delegates who were accommodating and said, absolutely, if we host the town hall, we would like for you to be here. So I am grateful for the opportunity to be here with you, share with you the process that we are undertaking, and also listen to what your thoughts and questions or concerns are. So I am grateful to be here. What you may not realize is that meetings like this are happening all over the state of Maryland and all over the country. And it's a result of the changes that we're experiencing in healthcare. I've been in healthcare for a little over 25 years, and I can honestly say that over the past 3 or 4 years, we've experienced more change in that short period of time than I have in the entire 25-year career history that I have. We are facing radical change. But what helps is having conversations like this. It's meetings like this where we can talk about the changes and talk about what our plans are. So while these meetings are happening all over the state and all over the country, what's different about this meeting, maybe from other meetings, is just where each hospital system is with regard to the planning process. Some of these meetings, you've got CEOs like myself who have already made decisions and who have already communicated those decisions without a lot of feedback and input. Others, like our healthcare system, are in the process of listening. We are in the process of communicating, and no decisions have been made at this point in time. So it varies in degree as to what these conversations are like going across the country. But I will, again, re-emphasize that at Shore Regional Health, no decisions have been made about the service delivery plan. Our board of directors, who is responsible for making that decision, has not voted on the service delivery plan. No decisions have been made at this point. But having said that, I think it's important to know what we've been doing over the last 18 months and how we're planning and preparing for a robust board discussion. What we've been doing over the last 18 months is talking to our community. I've had dozens and dozens of meetings with elected officials from all 5 counties, with key constituents in our communities, with groups of various different focuses, talking about the changes in healthcare. Talking about why things may not be able to be the way they are 5+ years from now, based on those changes that are coming about. In addition to those conversations, Shore Regional Health has put a lot of effort and energy towards putting a plan together that will address these changes. We've been doing that over the last 18 months, and today I'd like to take just a very few minutes to walk you through that process so you know where we are, what we've done, and where we intend to go moving forward. This will only take about 5 minutes, but I appreciate it because I think it may give you a perspective of where we are. In this new world, it was necessary for Shore Regional Health and all other hospitals likely across the country to reform their mission, reestablish why they exist in the communities that we serve. Our new mission at Shore Regional Health is creating healthier communities together. 4 words. Creating healthier communities together. That's what we're all about now. That is our roadmap for the future. And how are we going to achieve that? We have 5 basic goals. And I'll just go over each one very, very briefly, but it's important to know what we view as very important to our future success. The first goal, exceptional quality, safety, and patient experience. You can't be a healthcare system without providing high-quality care. It has to be done in a very safe manner. And you have to do it from a patient-friendly, patient experience perspective. That's goal number 1. Goal number 2 is in a rural healthcare system like ours, we have to be innovative if we're going to integrate our care. So use innovation, like technology, like computer systems, like telemedicine, to be integrated with the care that we provide from Rock Hall to Vienna and everywhere in between. From your doctor's offices to the hospital to the treatment areas where you get your diagnostic testing, all throughout the system. Be integrated with technology to provide high-quality care. The third is access to clinical services. We've got to make sure that we're providing access to our services. It's critical. We could provide the best services in the 5-county region or in Chestertown specifically, and if you can't access those services, we have failed. So making sure that we've got access to those clinical services throughout the region. The fourth goal focuses on engaging our team. 2,400 team members, hundreds of physicians that are part of our family, engaging them in the process so that we can make sure we're listening, we're engaging, and we're doing the right things for our entire organization. And the fifth and final goal focuses on our financial stability. Even though we are a nonprofit hospital, we need to make a profit, even as small as it may be, in order to reinvest back into our organization, reinvest back into the physician communities, bringing new physicians to our community, bringing new services, keeping our employees paid appropriately, giving them the right benefits so that we can keep our organization strong. We must remain financially strong. So those are the 5 goals that we've established. And with those goals, what we've done back in the summer of 2014 is we set up a work group. That work group was designed to answer the questions about what is going on at the federal level with the Affordable Care Act and other things. How does that relate to what's going on at the state level with regard to the new Maryland waiver and all of the changes that we're experiencing here in the state? But then more importantly, how does that apply to rural, mid-shore Maryland? How do we focus on that? So the work group was designed to pull in that information from a national perspective, a state perspective, and apply it to where we are today in rural Maryland. But in addition to those 5 elements of services that I talked about, there was one other area that we really made sure we needed to focus on, and that is transportation. In this community, in rural mid-shore Maryland, transportation is an issue. And again, if you can have the best services available, but if you can't get your patients to and from those services, they're not going to be appropriate enough. They're not going to be good enough. So it's critical that we created one plan that has transportation overlapping that particular plan. First and foremost, it's to listen. You being here is important to me, it's important to our organization. We need to hear your feedback in order to put the appropriate plan together. The second goal is to work hard to try to build trust. I know we've got a trust issue. Believe me, we've got trust issues from decades before I even got here, 4 years, 3 months, 7 days, 6 hours ago.
Goodness gracious.
We've got trust issues, but today's goal is hopefully a step forward in rebuilding some of that trust.
We were approved for 62 beds in 2008. That's when the University of Maryland came along. And I don't know the details how it happened, but I can tell you the ink was dry before I knew or any of the citizens knew that there was a done deal with the University of Maryland. With that in mind and the issues I was hearing about, I decided to let the community know ahead of time. So that's why you're here. At that time, in 2008, they made a bunch of promises. They sounded real good. The board of directors at the time fell for it. The problem is they hardly kept any of the promises. They did pump capital, mostly into the emergency room. It's a beautiful emergency room, which fits into any model that they want to use in the future. Urgent center, without inpatient care. They promised to have subspecialists come up here, and I think we have like an endocrinologist. That's a doctor who specializes in like diabetes. 2 days a month. To me, that's not a service, that's lip service. I'll get into how hospitals get reimbursed in a minute, which makes it more interesting. Not that it's not interesting yet, but. So, in the last few years, well, I should say, going back 2008, the Shore Regional tried to build a hospital back then. Recession hit, and that whole idea fell apart. Ironically enough, our number of our beds have steadily fallen since 2008 when the University of Maryland came. We're approved for 31 beds now. We were 62. We're in half since University of Maryland's been here. That's called enrichment from University of Maryland. So a couple of years ago, some consultants got together. Not sure why. And unlike what Mr. Kozel said, they didn't speak to me or any physician or any community members. Their conclusion was, and Mr. Kozel gave his presentation to me, a PowerPoint presentation, the last clause was, Chester River will be an ambulatory service hospital with or without a surgery center. And I said specifically, does that mean no inpatient care? He goes, that's correct. Now that's the conclusion of the consultants they gave to the board. These councils that Mr. Kozel speaks of, which I was on one of the councils, the surgery council, we were directed with, quote, how can we use the resources in the tri-counties or 5 counties to manage a new hospital. And I sat there and I contested every inch of the way. And they said, absolutely no inpatient care. I knocked heads with the chairman every meeting I went to. But they made it known in certain terms that there'd be no inpatient care here. So the decision was not a question of inpatient care or not, it was how do we manage the resources we have? How do we set up satellites here in Chestertown, Queenstown, Denton, and so forth? That's what I was charged with, and I refused to do it. Let's get to the meat of the matter, and that's why no inpatient care here is a really bad idea. Most importantly, it's unsafe, not to mention immoral. I had a conversation with Mr. Paul Parker from the Maryland Healthcare Commission just this past week, and I asked him point blank, is there a statute on the books where a patient should have availability to an inpatient care facility? He goes, no, but when I told him it'd be an hour and a half for Rockall people to get to Easton, he said, that's the furthest he's ever heard. Another term I like to talk about is market share. I can guarantee Ms. Kozell they will lose market share. All you people are very strong, proud people, and I think like I would, if Shore Regional is going to really ding us, I would, on my dying grave, go to a hospital other than Easton Memorial. Another reason why they lose market share, I don't know if Mr. Kozel knows this, but EMS, we have several members here, they're obliged by law to take level 1 and level 2 priority patients to the closest hospital. Right now, if that happens in the closest hospital from here is Elton or Dover. So all these patients will be lost to other hospitals under their new proposal of no inpatient care.
In our concerns in looking at the delivery of health care moving forward at Chester River Hospital, when this hospital changed due to the merger 2007, very controversial merger within the community. I supported that merger based on what I knew about the University of Maryland, their resources, their ability to invest capital, to bring in specialists, to really do for us what I thought would be better. And I have personally been very disappointed. I feel like they haven't delivered in many cases what was delivered, what was promised, or what was delivered was not promised. And that is one of the issues very concerning to me, personally. I've talked with Ken and been very upfront with Ken Kozell and my concerns. And, the numbers of diminishing admissions in the hospital, I said, well, when you keep reducing services, you're going to have diminished admissions. You cannot continue to reduce services. That are what they're looking for. And this is not my first rodeo when it comes to trying to sell a deal. It's often, whether it be in the marine world where you have 10 biologists you look at for a specific issue, you hire the biologist that's most tuned into your game plan. And consultants are no different. It's the same thing. This is politics, ladies and gentlemen. And they hire the people that are going to do what they want them to do. And for us in Kent County, it's very concerning. We have an aging community. We have a medium age that's higher than most counties, and a population which requires a lot of core services. And case being, very recently, with my mother, you go to the hospital under, whatever circumstances, you're required by Medicare to stay there 72 hours before you can be admitted to to the nursing home or wherever the next step may be. So under these proposed change, when you would have when you would no longer have that inpatient service, you'd have to be transported to Easton for 3 days and transported back. And all of this not only puts a strain on that patient, but that patient's family. And I can tell you how important the family is with anything that happens to a loved one.
I'm very emotional, I'm very committed to this, and forgive me for my fellow commissioners to maybe not be clear on this, but it's very, very important to us and for our survival. Not only economic development, the development for our children, and the development of our community. Washington College depends on a facility here. Yeah. This is not just Kent County, this is regional. We have, think about it, southern Cecil County, all of Kent County, Queen Anne's County, Caroline County, and a lot of parts of Talbot County rely upon the medical facilities that are right here in Chestertown. It is very important that we keep what we got and improve those services.
Yes.
I want to go back to what Dr. O'Connor was talking about, and if it's true that no decisions are made, that's a great thing. But what we keep hearing over and over again is that what the consultants are recommending is essentially that the hospitals in Cambridge and Chestertown get stripped down and really become feeders to a larger hospital that will be built one day at Easton. And that may work kind of okay for a place like Cambridge, that's not that far from Easton, or maybe Denton, or maybe even southern Queen Anne's County. But it really doesn't work well for Chestertown. Other numbers that we cannot ignore is a number like 24%. That is the percentage of our residents in Kent County that are over the age of 65. Look at the average age of this crowd. Does this sound like a good model for this population? To me, the numbers just don't work. Lastly, I'll come down to some other numbers. 27%. That is the amount of the population living in Chestertown at or below the poverty line. That number is 13% for Kent County, or twice the level of poverty you have in Queen Anne's County. So getting to Easton is not just an inconvenience for a lot of our population, it's in fact an impossibility. And it puts undue stress not only on the patients, but as Delegate Jacobs said, on our families. So for those reasons, I would urge Eastern Shore Health and UMMS to live by their own mission statement. Patients first, access first. And if it's true that they want to hear you, here they are. They are telling you loud and clear, based on the fact there's probably 200 people that didn't even get in here. We don't agree with the models and the rumors that we're hearing, and we want to make that clear before you tell us what you think is best for us.